we're coming close to the pretty close to the end of this panel with the mini workshop, which is going to be presented by Dr. Zahra Ghoreishi. She is a faculty member of the Speech Therapy Department at the University of Social Welfare and Rehabilitation Sciences. Her research interests include language processing, neuroscience of language, language learning, and language pathology. She's interested in interdisciplinary approaches in research, combining the novel neuroscientific methods in language research and conducting active collaborations with professionals in the field of linguistics and other relevant disciplines. She is pretty popular among the students and researchers that are interested in clinical linguistics in Iran. Dr. Ghoreishi research has also have a clinical direction and application. She has several publications and works related to the standardizing and validations of various assessment batteries and tests for both acquired and developmental language disorders. For example, she has compiled books related to developmental dyslexia in Persian and other books related to symptomatic guides to speech and language disorders, from definitions to diagnosis. Dr. Ghoreishi is going to talk today about the merits and limitations of neurostimulation techniques in language research. Dr. Ghoreishi, you will have 50 minutes to present.
Hello, can you hear me?
Yes.
Okay. Hello, everybody. Thank you, Dr. Bakhtiar, for your introduction. I'm very happy to be here. At this moment, I would like to appreciate Dr. Safavi and her executive team for arranging and holding this seminar. Okay, I hope my mini workshop is informative for you. Uh, my presentation is about merits and limitation of brain stimulation techniques in language research. Uh, let me review. Uh, Let me have a brief review about some basic concept that is necessary for this presentation. We will have a brief review about language, about the brain, and about the brain stimulation techniques. After that, we will talk about application of NIPS, non-invasive brain stimulation in language studies, and at last we will talk about cons and pros of brain stimulation techniques in language studies and neuroethics. Okay, what is language? As you know, language is a system of symbols and rules that is used for meaningful communication. Uh, a system of communication has to meet certain criteria in order to be considered as a language. A language uses symbols and has rules, and it is possible to generate infinite number of messages with limited symbols and rules for communication. Uh, as you know, we have three levels of language: phonology, morphology, syntax, semantic, and pragmatic. Please look at this in these slides and remember these levels of language when you faced with brain stimulation protocols. Based on the location of stimulation, you can suppose the level of language that is focused on brain stimulation protocol. Okay, we have an object of a study, name of field, and size of unit. When our research is focused on sounds, we are focused on a smallest size of units, and name of fields is phonetic. These are, I know, almost all of the audience are familiar with these topics, but these are very important for applying brain stimulation approaches to improving language or for therapy that in which field of language you are focused. Okay, we have a more practical theory level of language, form, content, and use. When we faced with some brain stimulation protocols that stimulate anterior areas of the brain, like frontal, prefrontal, its focus is on four. Okay, what we know about the brain, you can see a lateral view and a superior view of the brain, and we can talk about a view in micro scale or macro scale. When we talk about brain stimulation technique, our focus is on micro. Sorry. Uh, I want to active whiteboard. Okay. And I think, can you see the mouse now?
No, we cannot see that now. I guess you should activate it from the board.
Yes, I did.
No, we cannot.
And I choose marker. No, not marker, hand. Oh, sorry. What about now? Can you see the pointer or not?
Still,
Unfortunately, not.
No, okay. Okay. Forget it. We can continue without this application. Okay. What is brain? I love to review some basic concepts because I think we want to climb the ladder of science. We should remember the basic concept. It help us to have a common language, and it's I think a necessary step for starting every scientific work. Okay, as you know, brain is made of billion of nerve cells that communicate with each other through electrical and chemical signals. Uh, I think it's the basic concepts for brain stimulation techniques. We manipulate electrical signals in the brain, and because brain is responsible of our functions such as language, with manipulating these signals, we want to elicit some behavior. Okay, the another issue that is very important in brain stimulation, in applying brain stimulation, is that we know different region of brain are specific, are specialized for different function. It's a little bit related to localization, and these days, I think distributed parallel processing is more prominent than this approach. But when we stimulate a site of brain on the scalp, really we suppose that we believe in, localization. And we have another issue that we have two hemisphere. Left hemisphere that is typically more involved in language processing, and right hemisphere that is involved in spatial processing, in music processing, and so on. Uh, when I'm talking about the left hemisphere and language processing, my focus is in literal language. Because for understanding illiteral language like proverbs and metaphor, we need the participation of right hemisphere. And as you know, the brain is affected by a variety of factors, including genetic, environment, lifestyles, and brain stimulation techniques. Okay. Uh, the brain has a remarkable ability to adapt and change throughout life, known as neuroplasticity. It is one of neural bases of brain stimulation, rehabilitation, education, and learning. And brain maybe is damaged, and it is also vulnerable to a range of disorder, including neurodegenerative disorder like Alzheimer disease or other type of dementia, and a neurological disorder like epilepsy and stroke. But when we are talking about language studies, language disorder studies, and brain stimulation, I think the main focus of article is a stroke and primary progressive aphasia. That is a kind of neurodegenerative disorders. Okay. Um, here, here you can see two important features of the brain. Lateral fissure or Sylvian fissure. It's very important because we have a language zone. The other name of language zone is perisylvian area. It means those area of brain is located around the lateral fissure, and it's very important for us. And we have a central fissure or Rolando fissure that is very important for finding primary motor area and primary somatosensory area. Really, for running brain stimulation protocol, we need a brain map. And I like this map of brain because without any brain mapping, we can't do anything. We can stimulate any place of the brain, but it's necessary that we know exactly which location and which site of the brain we are stimulating, activating, or inhibiting. Here you can see the central sulcus and Sylvian sulcus, and the most important part of the brain that is involved in language processing, inferior frontal gyrus, that is IFG or Broca's areas, and superior temporal gyrus that you can see Broca's area here, and supramarginal gyrus and angular gyrus. I think activating brain areas or inhibiting brain areas are focused on these areas. Okay, we will have a brief review of brain mapping. It's sensory homunculus, and you can see sensory homunculus and motor homunculus that is introduced by uh, Penfield and his colleague. And it is a brain map of just M1 and S1, primary motor cortex and primary somatosensory cortex. And really, it was an innovation in science of the brain. We can talk about another map of the brain. We can divide the cortex into three areas: primary cortex, secondary cortex, and associative cortex. Primary cortex is in light blue, and associative cortex is in dark blue. And as you see, the dark blue is the most is the most part of cortex in primates and in humans. Okay, this is explanation of primary, secondary, and associative that you can study it. Okay. We can have another map of the cortex, the cerebral cortex. It's a functional map of cortex. You can find the location of that function, that behavior, that cognitive function you want in relation with the different part of cortex. Okay, for example, number 4, Broca's area is the location of word form, or uh, number 5 is auditory area. Okay, when we are working with brain stimulation neuronavigation system, we need a system for finding the place we want to stimulate. Okay, here you can see the map of Broadman's area. Here you can Broadman area 44, 45. That is, you can see F5 and F7. These areas are equivalent with Broca's area, or 22 and 42 areas, that is equivalent with Wernicke's area. And you can superimpose those those areas of Broadman with a 10-20 system electrode positioning. This system is based on uh, three distance: nasion to inion, tragus to tragus, and circum of the brain. Um, if you find the electrode you want to active, you can find it based on percent proportion. For example, if you want to find the FZ, you should go ahead 20% from CZ. And it's an international system for finding the brain area location on the scalp or a skull. And it has some rules. For example, FP is for prefrontal, F for frontal, T for temporal, P for parietal, O for occipital, and even number electrodes are related uh, mm, to right side of the brain, and the odd number refer to left side of the brain. It means, for example, if we want to activate Broca's area, we should focus on F7, or if we want to focus on homologue of area in right hemisphere, we should focus on F8. Okay, except 10-20 system, we have 5-10 system. The distance is mm, a little lower than 10-20 system. Okay, here there is matching between electrode position and function of that area. F7 is for verbal expression, for example, and as you see, T5 is for verbal understanding. In some articles, these are, equivalent with Broca's and Wernicke's area. Okay, here is another, combination of Broodman's area and functional area of the brain. When we talk about brain stimulation techniques, we have faced with many techniques, electrical techniques, I think, ECT, electroconvulsive therapy, is one of, uh, most common brain stimulation techniques, and we have magnetic and optical brain stimulation techniques. But in this workshop, we are focused on TMS and TDCS because these two techniques are more common in language studies than the other brain stimulation techniques. And TMS and TDCS are non-invasive brain stimulation that called NIBS in some researcher. Okay, let me talk about TMS. TMS is transcranial magnitude stimulation. Is a non-invasive procedure that uses magnetic field to stimulate nerve cells in the brain. Uh, we have a different pulse in TMS, and RTMS, repetitive TMS, is very important for us in therapeutic protocol. It's safe and non-invasive for the treatment of brain disease, especially aphasic patient. Uh, it is believed that low frequency RTMS exhibit inhibitory effects. When I talk about low frequency, it means lower than 1 hertz. And it's believed that high frequency RTMS higher than 5 hertz exhibit excitatory effects on the brain activity. When we want to run a TMS, we need MEP, motor evect potential, for starting our session. Okay, there is a basic law for applying TMS. This is Faraday's law of induction. When a magnetic field through a conductor changes, an electric field is induced in the conductor. As you remember, I told you we have billions of neurons which are connected based on electrical and chemical signals, and we can manipulate this chemical connection using medicines, and we can manipulate electrical connection applying brain stimulation techniques. It's another picture for mechanisms, for explanation of mechanisms of TMS. Because we are in short of time, I'd rather to skip some of my slides. Okay. I think the magnetic field generated by the coil, you can see here the coil, it's circle coil above the scalp of the subject. Okay, and the magnetic field generated by the coil, it's able to pass through the high resistant structures such as bone, fat, and skin without harming the body, and induce an electric field which depolarize neurons in the underlying tissues. Okay, and its response is motor activity or altered metabolism, or disruption in speech and vision, and etc. Okay, Let me escape this and this. Here you can see different type of stimulation in TMS. Low frequency RTMS, it means 1 pulse per second. High frequency theta burst, intermediate or continuous. Okay, let me talk about the advantages of TMS in language study. I think one of the most prominent advantage of TMS is uh, opportunity to make virtual lesion. As you remember, I talk about low frequency RTMS that can inhibit one area of the brain. Uh, Based on this characteristic of TMS, uh, TMS can be conducted in normal subjects, and I think, it is not necessary just we focus on lesion study, and uh, we can because of short lasting effect of TMS, we can repeat it in different subjects, and even we can repeat it in one subject for having long lasting effect. I think, in my opinion, I think the more advantage of TMS is the ability to making virtual lesion, and I think the more concern of brain stimulation technique, even TMS, is the short lasting effects. Okay, in TMS, we can target different areas of the brain. We can we can have a cause and effect approach, because in fMRI study, we are doing a correlational study, and we try to uh, you know uh, to find a correlation between both signal with a special brain area activity. Okay, but in TMS, we can excite or inhibit a special area of the brain, and after that, examine the behavior and cognition, language, and so on. Okay. TMS has some limitation. Uh, One of most prominent limitation of TMS is limited penetration depth and spatial resolution, and focality of stimulation depends on the geometry of the coil and other stimulation parameters. Uh, Accurate coil uh, placement is very important, and using non-navigated TMS is the preferred method for precise placement. I talk about 10 to 20 international electrode positioning, but usually it is not common in TMS study. Uh, TDC, TDCS is guided by 10 to 20 EAG system for electrode placement. Okay, in TMS, we have a secondary effect. Also, the stimulation is maximal on the cortical region, But the stimulation also has an effect on the connected areas of the cortex. For example, when the left motor cortex is stimulated, there are three likely effects of stimulation: change in activity in the targeted region, change in activity in immediately surrounding areas of the cortex, and change in activity of cortical areas directed connected with the stimulated region. Okay, you can see a basic TMS setup and neuronavigation setup that is very important MRI based or fMRI based neuronavigation setup for finding the region of stimulation in TMS studies. Okay, let's have a talk about TDCS, transcranial direct current stimulation. It's another form of brain stimulation. It's non-invasive, non-focal, deliver low currents of electricity on the following region. Okay, in the skull. In this method, and even in TMS patient is conscious, there is minimal comfort, and in TMS, we can see, a spike. We can see inhibition and excitation when you stimulate M1 for a time. You can for uh, for MEP, you can see the muscle twitch. Okay, but in TDCS just modulates neural activity. Neurons become more or less likely to fire, doesn't trigger any action potential. Okay, anodal TDCS, like high frequency TMS, is excitatory, and it's, related to uh, um, GABA neurotransmitter. It's reduced local concentration of GABA, and based on researchers, in GABA reduction occur with improvement in learning and performance. And cathodal TDCS, like low RTMS, low hertz RTMS, is inhibitory and reduce excitatory glutamate levels. Okay. In TDCS, we should pay attention to parameters of TDCS: current intensity, which determines the induced electrical field strength. But contemporary TDCS protocols used direct current up to 2 milliampere, and in many of them 1 milliampere is preferred. A stimulation duration is important. Electrode size is another parameter that should be uh, considered. Okay, here you can see a simplified picture of TDCS, a battery current direct, that is convey electrical signal into the brain. Okay. Here, you can see a standard position of a TDCS session. Okay. Uh, a subject sits in a sofa, relaxed, and the researchers or a therapist is behind, behind him, controls the TDCS device. And as you see here, A is the TDCS device, B is cathodal, B is anodal. Uh, okay, B. Okay, B is anodal. electrode is F3. It means DLPFC left DLPFC. D is cathodal. D is a strap. D is a strap. C is cathodal electrode that is placed in supraorbital. Okay, this is a typical design of TDCS in cognitive study. There is a question when which time is better to to having brain stimulation before task, intra or intra or post. Convention is to conduct behavioral tasks during or immediately after stimulation. It means we should have brain stimulation at first um, or simultaneously with behavioral task. Okay. There is some scientific concern about TDCS. Really, the current is very small, 1 to 2 milliampere is so tiny, and there is many doubts about the neural effect of TDCS is real or it is a placebo. And the effect size of behavioral changes after applying TDCS is very small. And sometimes say maybe it's a file drawer problem. It is uh, presenting just positive effect, not all of the effect of TDCS. Electrode placement is very crucial, but 1020 system is not as as exact as a neural navigating system and so on. Okay, let me uh, let okay. Let me escape of this. There are some concern about the practical safety. Side effect of TDCS is, subtle, but it's common. Uh, Nietzsche reports that um, only side effects that their participants have was initial scalp tingling and sensation of light flash. And some studies suggest skin irritation, and some of them, maybe patient faced with cognitive effects that are prolonged. And we should be noticed to the subtle side effect, and after that decide to choose brain stimulation techniques. We have, as I told you, we have many neurostimulated treatments that have FDA approved for depressed person, major depression, ECT, VNS, DBS, RTMS, and TDCS. Uh, Poor major depressed person, I think, try any new approach for treatment, and it is a comparison between these brain stimulation techniques. And as you see, RTMS and TDCS has a better situation and better scale from the others. Here, as you see, you can see some protocols for the applying brain stimulation techniques in depressed person. You can see protocol for RTMS, the target region is right or left DLPFC. It means F3 or primary motor cortex, and the protocol for RTMS is 5 to 20 hertz. It means it's excitatory protocol, high frequency RTMS. And for TDCS, the target region is left DLPFC or posterior parietal cortex, and the protocol is 20 minutes session, 1 to 2 milliamp per intensities. Okay, but for aphasia and for research in language study, we didn't have approved protocols. We just review some meta-analysis, RCT meta-analysis for finding protocols. As I mentioned, NIBS, non-invasive brain stimulation technique, applied in a language study in as a therapy method or as a research tool. When we talk about the brain stimulation technique as a therapy, we should mention that it is a complementary treatment. It's cannot be substituted with common and traditional speech therapy treatment. And it can use for brain boosting technique for language enhancement in normal adults for language learning, and for improving their language abilities. Uh, there these days there are some uh, uh, some potential for applying brain stimulation technique in healthy individuals. Unfortunately, I wanted to put the summary of research in healthy subjects. I think here you can see the original paper that I bring its table from that. But when I review my slides, I understood that I had, I put a wrong table here. But there are many articles that applied brain stimulation techniques in healthy individuals. And you can find the parameters of, for example, region of stimulation, protocol, and even design of research for finding the best protocol for your research or treatment. Here is, it is from another paper. You can see some articles applying a TDCS in healthy volunteers, and result was that TDCS was significantly better in learning and recognition in new vocabularies, and its benefits was uh, maintained at 1 week follow-up. Really, follow-up is a very its main problem of brain stimulation techniques and even effect size. Uh, because maybe based on statistics, we found significantly improvement in for example, in vocabulary and something else, but maybe it is not very important in real life, or its effect size is so low. Okay, and in another research, they didn't find any significant difference on performance in a normal subject. Okay, uh, I forgot to say when we have applying brain stimulation technique, we should compare this, intervention group with control group. Control group of brain stimulation groups is sham group. Sham for TMS and sham for TDCS. Okay. Uh, and in the papers compare these patients, these two groups with each other. Uh, um, as I told you, Alzheimer disease and the other dementia person, especially primary progressive aphasia, are a group of participants that is running many research relating to brain stimulation um, for them and its effect. Okay, uh, let's have a talk about the application, about the using TMS or TDCS as a therapy for aphasic patient. As you know, aphasia is a language disorder caused by damage in a specific area of brain that is responsible for expression and comprehension, and based on the origin of damage lesion site, or based on performance of patients in comprehension, influence, and repetition, we can have 8 different type of aphasia. I like this aphasia decision tree. It's very helpful for diagnosing different types of aphasia. But if if I want to summarize this slide, I must say we have two type of aphasia: non-fluent aphasic patient and fluent aphasic patient. The non-fluent aphasic patient have damage in anterior part of their brain, and fluent aphasic patient have damage in posterior part of their brain. If we use auditory comprehension and repetition task, we can diagnose, differentiate the 8 type of aphasia. Okay, and there
Sorry,
is
Dr.
oh yes,
Sorry,
please.
Dr. Ghoreishi, you have 5 minutes left for your presentation.
Okay, okay, okay.
Thank you.
I will try to finish it on time. When we apply brain stimulation technique in aphasic patients, we should notice the phase of recovery. I mean, post-stroke time. If the patient is in acute phase, it means 2 weeks after the onset of lesion, the patient is in acute phase, and if it is in 2 to 12 weeks after, usually a stroke lesion time, it's in subacute phase, and when it is in 6 months after a stroke, it is in chronic phase. And many of the studies which use the brain stimulation technique for aphasic patients, they are in chronic phase, and really there is difference between these 3 phases. Okay, for applying NIBS for aphasic patients, there is a fundamental theory. After the patient encountered a lesion in left hemisphere Broca's area, as you see in blue color, we see decreased excitability in affected hemisphere and affected uh, region. And we see increased excitability in unaffected hemisphere. We have two solutions, and the activity of the unaffected hemisphere is not, beneficially for subject. It's a maladaptation, and we need to decrease that activity for better performance. And the basic of the applying brain stimulation technique in a phasic patient is activating left hemisphere, for example, Buruka, and deactivating or decrease activity in homologue of Buruka in right hemisphere. Okay, and you can, it's a brief common protocol in aphasia therapy. In many articles, use 20 minutes non-invasive brain stimulation plus 45 minutes speech therapy. In 10 days, in 2 weeks, it will be helpful for patient, but I'm not agree with 3 times better. Okay, TDCS is inexpensive, and its application is easy. It's safe and non-invasive. It can be used in a wide range of environments. It's portable and uh, can be used as a in combination with other rehabilitation therapies. But there are some concerns that I mentioned before. Really, there is no a standard protocol for applying TDCS, and you know the its current is so tiny, and sometimes there is a stigma against use of electrical stimulation, and maybe the patient don't like to apply brain stimulation. But I want to just say some brief explanation about the neuroethics of non-invasive brain stimulations. Refers to ethical considerations about the use of brain stimulation NIBS in research and clinical setting. Okay. Uh, uh, Non-invasive brain stimulation has this potential to use for enhancement purpose rather than just therapeutic purpose. For example, uh, we can use it can use to enhance cognitive abilities such as memory, attention, and it has potential for it to create a brain boosting device. I will finish in 2 minutes.
The
Uh,
time is up. I would appreciate if you
oh,
just,
I will
try to be
finish in
on.
2 minutes. Okay.
Yeah.
Thank you. Uh, this could exacerbate existing social and economic inequalities. Okay, it means divide people into at least two groups who can use these techniques and boost their abilities, and those can't use. Okay, another ethical concern is the potential for non-invasive brain stimulation to cause harm. Uh, you know. Uh, there is a potential for psychological harm if individuals feel pressed to undergo non-invasive brain stimulation for enhanced purposes. Uh, okay, there are another, uh, another ethical concerns around the use of non-invasive brain stimulation in research. Uh, it is important to ensure that that participants fully understand the risk and benefit of NIPS before they agree to participate in a study. Finally, uh, there are ethical concerns around the use of NIPS in clinical practice. It is important to ensure that non invasive brain stimulation is only used when there is a clear clinical need. And it is not okay we overestimate the effect of brain stimulation technique to convince our patients to take participate in our research or come to our clinic. Okay, I should say, and I think it is the last one. Uh, While non-invasive brain stimulation has the potential to offer significant benefit, it is important to carefully consider the ethical implication of its use in research and clinical setting. Thank you very much for your attention, and I hope it was informative and practical for you. Thank you.
All right, thanks a lot, Dr. Ghoreishi, for a comprehensive review of neurostimulation for language disorders. Uh,
Okay.
all right,
Thank you very much.
thank you very much, Dr.
You're
Ghoreishi.
welcome.